Assalamu alaikum, everyone. My name is Attas Alattas. I'm a fourth-year medical student. And today I will be explaining to you the glomerular filtration and the renal plasma flow lecture. This lecture is a pretty easy lecture. I'll try to make it as simple as possible. And whenever you have any question, you can write it down in the chat, and I'll try to solve as many questions as I go through the slides, or whenever we reach the checkpoint, inshallah. Okay. Do you see the full screen? Okay, perfect. 1 second. Just give me a second. I'm trying to remove the subtitles. I don't know how. Okay, perfect. So today we'll be going over these concepts. We'll be first explaining the characteristics of the glomerular filtration barrier, then discuss briefly the glomerular diseases, and then move on to the glomerular filtration rate and renal plasma flow, and finally touch on the autoregulation mechanisms. Okay, so first we have okay, so first we have the morphology of the glomerulus, the glomerulus itself. So the glomerulus is the filtering unit of the kidney, or the functional unit of the kidney. So the kidney has multiple functions, one of which is the filtration, and it's the only organ in the body that does the filtration. So whenever you hear the word filtration in the body or excretion, you will always think about the kidney or the glomerulus. So the glomerulus is a structure in the kidney, so it is enclosed by the Bowman capsule. So it's the loop of capillaries. These loops are capillaries, and they're enclosed by the Bowman capsule. So this Bowman capsule with the loop of capillaries, they're called the glomerulus. So how does the glomerulus receive the blood? It receives it from the renal artery. So the renal artery bumps the blood to the glomerulus by the efferent arteriole. So the renal artery becomes the efferent arteriole becomes the glomerular capillaries, and then from there it becomes the efferent arteriole, and from there it becomes the peritubular capillaries. So for any substance to be filtered, it has to go through a filtration barrier, and the filtration barrier consists of 3 layers, and these 3 layers are the capillary endothelium, okay, then the basement membrane, and then the podocytes, or the epithelium. And we'll go into that. I'll explain further in the next slides. Now, 20% of the plasma will be filtered through this filtration barrier. So when I say filtration barrier, you always think of these 3 layers: the capillary endothelium, basement membrane, and the podocytes. So this filtration barrier, it decides which materials will go or which substances will be filtered and how much will they be filtered, okay? And when they are filtered, they get filtered into the Bowman space, and from there they go into the tubules. So as I said, the filtration barrier consists of the 3 layers: the capillary endothelium, basement membrane, and the podocytes. So this is just another image illustrating you the 3 barriers. You have the endothelium here. So this is, if we're looking from this side, this is the capillary lumen. We have the endothelium of the capillary, and the endothelium of the capillary has pores, okay? And I'll explain to you later what's the function of these pores. Then there's the basement membrane, okay? It's in between the endothelium and the epithelium. The epithelium is another name for the podocytes, okay? And then we have the epithelium or the podocytes, and these podocytes, they have like foot-like processes, and in between these foot processes, you have this filtration slits, and where the substances will move from the capillary lumen into the Bowman space. So this is just a microscopic, both are microscopic images from the glomerular capillary. This is from inside the glomerular capillary. So you're looking from inside the capillary lumen. You can see that there are some pores in the capillary lumen, and these their function is to allow the materials or the substances from the capillary to move into the Bowman space. And these are in this picture, you can see that there's the podocyte, okay? And the podocyte has the food processes. And these food processes, they have what? They have the filtration slits, which also allow for the filtrate to go from the capillary lumen. So this is the capillary, and this is the podocyte. It has food processes. And from the capillary, it goes outside into the Bowman space, okay? This is so far what you need to know from these two microscopic images. So now we'll dive into the three filtration barrier layers. We said that there is the endothelium, the first layer from the outside, from the capillary side, is the endothelium, and it has pores. We said the pores are 50 to 100 nanometer, and the reason that they're in this size is because they prevent the cells. So why do you think they prevent the cells from passing from the capillary to the Bowman space? Does anyone have an answer? So if small pores, so don't get large. Okay. No, they're not negatively charged, but the reason is because cells are more than 100 nanometer, so they're unable to pass through the endothelium. So cells like white blood cells, RBCs, they're unable to move from the capillary to the Bowman space because of the pore size. The pore size is of 50 to 100 nanometer, and cells are usually greater than 100 nanometer. That's the reason why they're not negatively charged. This is for the endothelium layer. The next layer is the basement membrane layer, and the basement membrane is made up of proteins, and proteins are negatively charged. So remember in the plasma you have the plasma proteins. So the basement membrane is also made up of proteins. So proteins in the basement membrane are negatively charged. Proteins in the plasma membrane are negatively charged. So they repel each other. So that's the reason why plasma proteins are unable to be filtered. This is for the basement membrane. The next layer is the epithelium or the podocytes, okay? So it has slots that are 20 to 50 nanometer. So even if the cells were able somehow to get to pass through the endothelium, they won't be able to pass through the epithelium, okay? And this is the function of the podocyte is also to prevent the proteins from being filtered. So again, the three layers are the endothelium, okay? It prevents its main function is to prevent the passage of cells from the capillary to the Bowman space. Then you have the basement membrane. It's made up of negatively charged proteins, so it prevents the penetration of the plasma proteins, because both plasma proteins and the proteins that make the basement membrane are negatively charged, so they repel each other. And finally, the epithelium or the podocyte layer, and it also prevents the penetration of the plasma proteins. So now that we're done with these three layers of the filtration barrier, let's move on to talk about the macromolecules, or the molecules that will be filtered in the kidney. So there's a rule that says that molecules that have a radius that is less than 18 angstrom, will be freely filtered. So if they're less than 18 angstrom, they have a radius of 18 angstrom or less, they will be freely filtered. If they have a radius of 42 angstrom or more, they will not be filtered. And if they have a radius of 18 angstrom or in between 18 and 42, they will be partially filtered. And I will tell you what do we mean by partially filtered, okay? But keep in mind this concept that below 18 angstrom, they will be freely filtered. More than 42, they will not be filtered. Between 18 and 42, they will be partially filtered. And we'll get into how they're partially filtered. Just keep this concept in the back of your head. Okay, so for substances, we said that for substances that are between 18 to 42, they're partially filtered. And what do I mean by partially filtered? Their filtration, it depends on two things: the size of the molecule and the charge of the molecule. So let's first talk about the size of the molecule. So what do you think a molecule that has, let's say 20 angstrom, a radius of 20 angstrom, and a molecule that has 30 radius of 30 angstrom, which of the two do you think is more likely to be filtered? The 20, yes, because the lesser the radius of the molecule, the more it's likely to be filtered. So this is it depends. So we said two factors. It depends on the size and the charge, and this is related to the size of the molecule. So the less the radius, the more it's likely to be filtered. More radius, it will be less likely to be filtered. And now moving on to the charge of the molecule. So remember when we said that the pore itself is made up of proteins, and the proteins are negatively charged. So what do you think? A molecule that is positive or negative will be freely filtered more? Positive? Are you sure? Okay, I'm just kidding. Yeah, it's positive. Why is it the case? Because a positive molecule, okay, the pore is negatively charged. So if there's a negatively charged molecule that will pass through the pore, it will be repelled by the negatively charged pore. However, if there's a positively charged molecule, it will not be repelled. It will be attracted, and therefore it will be filtered more than a negatively charged molecule. So again, just to make it clear, for 18 to 42 angstrom molecules, the filtration depends on two factors: the size of the molecule and the charge of the molecule. Size, if it is more, if they have a radius of, let's say, closer to 42, they're less likely to be filtered. Radius of that is close to 18, they're more likely to be filtered. So the more size, the less they are likely to be filtered. The charge, positively charged molecules are more likely to be filtered than negatively charged molecules for the reason that I explained. Now, for substances that are less than 18 angstrom, we said that they can pass freely because they have small sizes, and they're the main reason they can be freely filtered is because they have small sizes. So the distance between the substance and the negatively charged pore is so big that it won't affect the molecule itself. So for molecules that is less than 18 angstrom, they will be freely filtered because they have small sizes. They won't be affected by negatively charged pore. However, for 18 to 42, the size and the charge of the molecule matters. Okay, so this is just a graph that explains the same thing. So we have on the y-axis we have the filtration rate, so how much a molecule is filtered, and in the x-axis we have the radius of the molecule. So let's take this one, the neutral dextrane. Neutral dextran means it has no charge, not a positive or a negative charge. So we said that for molecules that are between 18 and 42, the more the radius, the less the filtration. And this is you can see that from the graph. The more the radius, the filtration rate gets decreased. Okay. Now compare that to a positively charged molecule. This is polycationic, means a positively charged. So for the same radius, so let's take 30 for example. For the same radius, a neutral substance would have filtration rate of 0.4. However, a positively charged molecule, let's say, has a filtration rate of 0.8. So you can see that for positively charged molecules, they have more filtration than a neutral or a negatively charged molecule. The opposite is for the negatively charged molecules. So the same goes for the negatively charged molecules. For 30, for the same radius, you can see that the filtration is almost 0. However, for neutral, it's more. And for positively charged molecules, it's the most. Is this concept clear, by the way? Okay. Okay, so these substances are okay. So these substances are the substances that are filtered in the kidney. Okay. Okay. So you have all of these substances that are filtered in the kidney, and look at the molecular radius. We said that substances that are below 18, they are freely filtered. And if you notice that until inulin, okay, until the substance inulin, the filterability or the filtration rate for this molecule is almost 1 or 100%. Okay. However, when you come to myoglobin and the substances like albumin, hemoglobin, albumin, they're all proteins, and they have molecular radius that is between 18 to 42. You can see that myoglobin has 19.5, albumin 28.5, 32.5, and 35.5. And if you notice that in these molecules, since they have a molecular radius that is between 18 to 42, their filterability is not 100% or 1. For myoglobin, it's 75%, let's say, albumin 22%, hemoglobin 3%, and albumin is less than 1. This is one thing to notice. The other thing you can notice that the trend of the molecular radius with the filterability. So the more you increase the molecular radius, the filterability decreases. So this is what we meant by the size of the molecule. The more you increase the size, the less the filterability is. For hemoglobin, one more thing to mention in this slide. For hemoglobin, usually hemoglobin is not free in the plasma. So this is the 3% is when the hemoglobin is free in the plasma. However, hemoglobin is always packed in RBCs, and we said that RBCs are not freely filtered because of the what? Can someone? Because of the capillary, the endothelium capillary. Yeah. So because of the endothelium, the RBCs are not freely filtered. They cannot be filtered because of the capillary, the endothelium. That's why hemoglobin has a filterability of 3% if it is only free, if it is like free in the plasma. And this happens in cases where there is, let's say, the RBCs are broken down and hemoglobin is released into the plasma, then you would see a filterability of 3%. However, usually in normal cases, the hemoglobin is usually packed in the RBCs, and RBCs are not allowed to be filtered because of the endothelium of the capillary. Okay, so remember when I said that molecules that are less than 18 angstrom, they are freely filtered with no restriction, and the charge of the substance doesn't matter. Well, this is not always true. Okay, so for these molecules, the molecules that are less than 18 angstrom, they're usually ions. Okay. And the charge of the pore doesn't affect their filterability. However, one thing that affects their filterability is the plasma proteins. So okay, so let's assume that this is the plasma. Okay, the plasma proteins in the plasma are negatively charged. And you have the molecules that are less than 18, the sodium and the chloride. So what do you think will these substances, their filterability will be? Do you think sodium will be filtered more or chloride will be filtered more? Chloride will be filtered more. No, yeah, it is chloride. And why do you think it's chloride? Yeah, because of the negative proteins. Yeah, exactly. Because the plasma proteins are negatively charged. Okay, so it will attract the positively charged molecules, and it will cause less less of them to be filtered in the kidney. However, because the plasma proteins are negatively charged and the ions that are negatively charged have the same charge, they will repel each other, so more chloride will be filtered. Is that clear? Okay. So this is called Donan distribution. Donan distribution is when these molecules, the molecules that are less than 18 angstrom, the pore charge doesn't affect their filterability. However, the plasma proteins, because they're negatively charged, it does affect their filterability. So molecules that are or substances that are positively charged will be filtered less. Molecules that are negatively charged will be filtered more because they will repel each other. It is opposite to the what? To the molecules of 18 to 42 angstrom. There we said that molecules that are positively charged will be filtered more. Molecules that are negatively charged will be filtered less. So this is the opposite here. Here it says ultrafiltrate contains all plasma substances which can be filtered. So do you think the RBCs is considered an ultrafiltrate? Yeah, exactly. Ultrafiltrate means that any substance that is in the plasma, okay? So ultrafiltrate, the plasma substances that can be filtered in the kidney are called ultrafiltrate. So if a molecule or a substance cannot be filtered in the kidney, it will not be called ultrafiltrate. So this is why RBCs are not considered as ultrafiltrate. These substances are considered ultrafiltrate because they can be filtered. However, for RBCs, they're not ultrafiltrate because they cannot be filtered. We'll come to the filtration load in a bit. Is this slide clear, everyone? I'm just making sure that we don't move on to the next slide without understanding the previous slides. All clear, everyone? Perfect. Right. Now we move on to the second part of our lecture, the glomerular diseases. So the glomerular diseases are two diseases or two categories of diseases. There's the nephritic disease and the nephrotic disease. The difference in these diseases, so for you to decide if this disease is nephritic or nephrotic, it depends on the site of glomerular injury. So remember when we said that the filtration barrier has three layers: the endothelium from the capillary side, and then the basement membrane, and then the podocyte. Okay, so if there's an injury to the endothelium, it will be called nephritic. Okay. However, if the injury is in the podocyte, it will be called nephrotic. And the way I like to remember this is nephrotic has an O and podocyte has an O. So this is how I always remember nephritic and nephrotic. Okay. Yeah, we said two categories, nephritic and nephrotic. The determinant of whether a disease is nephritic or nephrotic is the site injury. If it is in the endothelium, it is nephritic. If it is in the basement membrane, it is in the podocyte, it is nephrotic. So what is the difference between nephritic and nephrotic? In the nephritic, where the injury is in the endothelium, we said that the endothelium prevents what substances exactly? The cells. So when there is a nephritic disease, okay, the injury is in the endothelium of the capillary, and there will be an inflammation. And because of the inflammation, there will be the cells, the red blood cells and the white blood cells will be spilled into the urine, because that barrier that prevents the cells not to be filtered is gone. So now the cells, the red blood cells and the white blood cells can be seen in the urine. This is one thing that you can see in nephritic. Okay. The other thing you can see in nephritic is mild protein loss. This is for the same reason. You're losing the endothelium layer. So a few only proteins will be spilled into the blood, into the urine. Also, because there is an inflammation in the glomerulus, because of the inflammation, the blood going into the kidneys will be less. And because there will be less blood going into the kidneys, this will decrease the GFR, or the glomerulus filtration rate. And because there will be less GFR, the substances that the kidney needs to remove will build up in the blood. These substances are like the blood urea nitrogen, like ammonia. All of these substances will build up in the blood, and this is what is referred as to azotemia. Okay, and because now less GFR is there because of the inflammation, so you're not filtering more. So you're not filtering more. There will be less urine. Okay, there will be buildup of substances like blood urea nitrogen, and because there is an inflammation, the kidney will react by what? By activating the renin-angiotensin system, and this will cause hypertension. And because there is protein loss, there's mild edema. So again, in nephritic, the injury is where? It is in the endothelial cells. These endothelial cells, they prevent the cells from being filtered. Now, because this layer is injured, cells will be seen in the urine. This is what's written here. Red and white cells will be seen in the urine. Okay, and because the glomerulus itself is inflamed, there will be less blood going into the kidney. Okay, and because there's less blood going into the kidney, the GFR will be reduced. And because the GFR is reduced, you're not filtering a lot of substances, so there will be built up of the waste materials like the blood urea nitrogen in the blood. So this is referred to as azotemia. And because of the decreased GFR, you're also not producing too much urine. So there will be reduced urine volume, or another name for reduced urine volume is oliguria. And also because of the activation of the renin-angiotensin system, there will be hypertension. And I'll explain the renin-angiotensin later in one of the slides. However, for now, just understand that the activation of renin-angiotensin system will cause hypertension in nephrotic disease. And finally, edema because of the protein loss. Is that clear? The concepts of nephrotic and nephrotic are beyond your level. However, I think Dr. Shams will not bring questions about them. So I will just go briefly on these slides. Okay. So nephrotic, and for nephrotic, we said that nephrotic, the damage or the injury is in the podocytes. And we said that podocytes are responsible for not allowing the proteins, the plasma proteins, to be filtered into the Bowman space. Okay. So because the podocytes, the layer that prevents the proteins to be filtered, is gone, now you will have more protein loss. Okay. And because there is protein loss, there will be what? Edema. Okay. And there will be no change in the GFR because there's no inflammation. And there will be normal urine volume. Why is there a normal urine volume? Because there's no inflammation. So because the injury is in the podocyte, there will be protein loss. Because there's a protein loss, there will be edema. Okay. And because the nephrotic syndrome is non-inflammatory disease, so there will be no change in GFR, and the urine volume will be normal. Okay. However, there's one significant thing in nephrotic is that the urine will look foamy, because the proteins will be more in the urine, and it will cause the foamy appearance of the urine. So this is for the nephrotic and nephrotic. Do you want me to explain it again, or is it clear? Yes, explain, or yes, proceed. Perfect. Okay. So this is just some numbers for you to read. You don't have to memorize these numbers. He will not ask you about it. It's just telling you that the weight of each kidney is 0.15 kilograms. So you have two kidneys. So total of 0.30 kilograms. Number of nephrons is 2.5 millions. Total area of glomerular capillaries is 3 meters squared. And total area of all pores is 0.15 meters squared. You don't have to memorize any number again. Okay, so this is the checkpoint slide. I will review the filtration of the molecules again. But if you have any questions, please write them down now. About anything that I have just explained. Okay, so if there's no questions, I'll just, okay, I'll explain it here. Any other questions? Okay. So for the for okay, so we said the macromolecules come in different sizes, or they have different radiuses. Okay, so for molecules that are less than 18 angstrom, they are freely filtered. Okay, they're not affected by the negatively charged pore. However, they are affected by the plasma proteins, and this is what's referred to as donor distribution. Let me go back to the slide. Donor distribution. Okay, so we said that these molecules, they are ions, okay, and they're affected by the plasma proteins. How are they affected by the plasma proteins? The plasma proteins are negatively charged molecules. Okay, if an ion is positively charged, it will be attracted by the negatively charged plasma protein, so it will be less likely to be filtered. However, if a molecule or an ion is negatively charged, it will repel the negatively charged plasma protein and it will be more likely to be filtered. This is for the donor distribution. It's only applicable to molecules that are less than 18 angstrom. Okay, so the Donan factor, you don't have to memorize it again. It's just telling you that it's basically dividing the concentration of the sodium in the ultrafiltrate divided by the concentration of the sodium in the plasma. It tells you that if you divide this over this, you'll get 0.95, which is telling you that the filtration is nearly 1. It's the same for chloride divided by the chloride in the plasma divided by the chloride in the ultrafiltrate. Its filtration is nearly 1, which means that wait, let me okay. So for these substances in the sodium in the ultrafiltrate is divided by the sodium in the plasma. It's equal to 1. Okay, the chloride in the plasma is divided by the chloride in the ultrafiltrate is equal to 1. This tells you that the sodium is more likely to be filtered if it is in sorry. Um, so basically, thing is, I don't really remember the explanation of this. However, the doctor did not go over it like extensively. So the doctor, when he explained the Donan distribution, he did not extensively explain the formula. However, you can refer to his video for more explanation. I remember I know the explanation. However, right now I cannot explain it. Okay, so we said for molecules that are 18, that are negative, less than 18, they're freely filtered, affected by the plasma proteins. We knew how. Molecules that are between 18 to 42, they're partially filtered. They're dependent on two things: the size and the charge. The more the radius of the molecule, the less likely it will be filtered. Charge, if it is positively charged, it will be attracted by the negatively charged pore, so it will be filtered more. Okay, 42 and more will this is more than 42, it will not be filtered. Okay. Any other question? Okay, for the person who asked about the R factor, I'll have to refer back to the recording and get back to you, or look it up on the internet, and I will make sure to explain it in the slides, in the last slide. Okay, when you receive the slides, you will have the last slide will be an explanation of the R factor. Okay. Now let's move on to the GFR and renal plasma flow. The filtration rate or the load. So this is for individual substances. So for you to know how much substance is filtered in the kidney, you multiply the GFR. GFR is usually constant. It is, yeah, it's not going to be tested. But just for you to understand if you want. Okay, so GFR is always constant. It ranges between 175 to 180 liters per day. So for you to know how much, for example, sodium is filtered in the kidney, you multiply the plasma concentration of sodium, okay, multiplied by the GFR. So 140 multiplied by 175, it gives you 24,500,000. And the same goes for the other substances. But from this table, you can notice that most of the substances that is filtered is sodium and chloride. Okay, the other substances are less filtered than sodium and chloride. So when it comes to reabsorption, you also have to account for these two substances, the sodium and chloride. And you can see in the reabsorption that sodium and chloride will be reabsorbed by 99.6 and 99.4. Again, you don't need to memorize any numbers in this lecture. However, just for you to understand that for you to calculate the load of any substance, whether it's sodium, chloride, bicarbonate, potassium, water, you multiply the plasma concentration of that substance by the GFR, and you get the load. Okay, and from the reabsorption column, you can realize that all substances are reabsorbed by more than 99, except for potassium. Okay. Now, for in any capillary in the body, it has these forces that play a role in the filtration and the reabsorption. Okay, so what are these forces? They are called the Starling law forces, and there are like 4 forces that you need to memorize. These are the hydrostatic pressure. Okay, it's the capillary hydrostatic pressure. It pushes the fluid or the fluid from the capillary into the interstitial. You have the interstitial hydrostatic pressure. It's the same but opposite. So the same in terms of it pushes the fluid to the opposite side, but it's opposite in terms of the direction. So interstitial pushes the fluid in the opposite direction. So it pushes the fluid from the interstitium to the capillary. The colloid osmotic pressure in each the capillary or the interstitial pulls the fluid to its side. So if the difference in the hydrostatic pressure is more than the difference in the colloid osmotic pressure, you would have filtration. So if this difference, if the capillary hydrostatic pressure minus the interstitial hydrostatic pressure is, let's say, 100, and the colloid osmotic pressure and minus the interstitial osmotic pressure, let's say, is 50. Okay, so it's the net pressure is 50. So you would have 50 pressure of hydrostatic pressure. So there will be a pressure of 50 pushing the fluid into the interstitium. Okay, And the opposite is true when you have the colloid osmotic pressure. The net effect, the difference in the colloid pressure is more than the difference in the hydrostatic pressure. You would have reabsorption. Okay, so in the glomerular capillaries, you don't have filtration and reabsorption. You only have filtration. And why is that? Because before I go and explain this, this is the glomerular capillaries. Okay, in the glomerular capillaries, you have the same forces: hydrostatic pressure of the capillary, hydrostatic pressure of the interstitial hydrostatic pressure, or the Bowman's space hydrostatic pressure. You have also the capillary colloid osmotic pressure, but you don't have the Bowman space colloid osmotic pressure. And why is that? Because usually there's no proteins filtered in the glomerular capillaries, unless you have a disease, which we explained before, the nephrotic disease. Then you would have proteins in the Bowman space. However, normally you don't have the Bowman space colloid osmotic pressure is usually 0. So you have like 3 forces that are acting on the glomerular capillaries, and these 3 forces decides the filtration. Okay, so in the glomerular capillaries, the hydrostatic pressure of the capillary is constant. And why is that? Because the glomerular capillaries, the resistance there is less. So the reason they are less, because the arterioles and the capillaries itself, they have wide radius. They have a wide radius. Because there's a wide radius, you have less resistance. So the hydrostatic pressure will not change throughout the capillary, unlike the systematic capillaries, which have an increased radius. So the hydrostatic pressure in the capillary will reduce along the capillary. So this is one thing to note, that the hydrostatic pressure in the capillary of the glomerular capillaries is constant, and the Bowman space hydrostatic pressure is also constant. So what determines the filtration? It's the oncotic pressure, or the oncotic colloid osmotic pressure. So when you have hydrostatic pressure, when you increase the hydrostatic pressure of the capillary, you're filtering more. Okay, and as you filter more, so more fluid is going into the glomerulus. The proteins in the capillary will increase, so they will precipitate. So the colloid osmotic pressure will increase until a point where they reach the hydrostatic pressure in the capillary. So they will be equal. So the hydrostatic pressure of the capillary will be equal to the colloid osmotic pressure in the capillary. And in that case, the filtration will stop. Okay, that's the reason why in the glomerular capillaries you don't have reabsorption, because filtration will stop. So you won't have precipitation of proteins. Which slide? Sorry, I just saw it. Is it this slide or the previous slide? What about case of? Okay, yeah. So this guy is asking why there's zero. The Bowman space oncotic pressure is 0. Is that the question? Why is it 0? Okay, so because we don't usually filter proteins. We said earlier that proteins are not allowed to be filtered because of the basement membrane and the podocytes. So because the podocytes are and the basement membrane is intact, so the proteins will not be filtered into the Bowman space. However, if the podocytes are diseased or injured in the case of nephrotic disease, you would have an oncotic pressure in the Bowman space. Is that clear? Okay. So we said that in the glomerular capillaries we only have filtration. There's no reabsorption, unlike the systematic capillaries. In the systematic capillaries, you would have filtration in the beginning of the capillaries and reabsorption at the end of the capillaries. This is because in the systematic capillaries, the hydrostatic pressure will decrease along the capillary. However, in the glomerular capillaries, the hydrostatic pressure is constant throughout the whole capillary. Okay, and what decides the reason it is only filtration is because when you filter the fluids, the fluids will go from the capillary into the Bowman space. So as you filter the fluids, the oncotic pressure here will increase. So as you can see here, it will increase because you're removing fluids and you're only leaving the proteins there in the capillary. So as if you're increasing the proteins there, okay, the proteins pressure, they will increase to an extent where the hydrostatic pressure in the capillary and the oncotic pressure in the capillary is equal. So when they're equal, we said that the filtration will stop. Remember before when we said here that if the difference of the hydrostatic pressure is greater than the colloid osmotic pressure, there will be filtration. But if the colloid osmotic pressure is more than the hydrostatic pressure, there will be reabsorption. Here, the oncotic pressure will increase until to an extent where it becomes equal. So when they're equal, the filtration will stop. There will be no reabsorption. This is the reason why there's no reabsorption in glomerular capillaries. Is that understood? Because this part is a bit confusing. Okay. So for glomerular capillaries, just one more time, it's the colloid osmotic pressure in the capillary that decides the filtration, because the colloid osmotic pressure will increase to the point where it's equal with the hydrostatic pressure, and then the filtration will stop. So when filtration stops, okay, the oncotic pressure will not increase. Why will it not increase? Because there's no filtration. So the oncotic pressure, the pressure in the capillary will stay the same. So the oncotic pressure in the capillary will stay the same. This is equal. This equal point should be beyond the efferent arteriole, right? Or is it during the glomerulus? I did not get your question. So what I mean is that from the beginning of the capillaries, it will start, the oncotic pressure will increase until you reach the end of the capillaries where the filtration will equal the hydrostatic pressure will equal the oncotic pressure. So this is where there's no more filtration, and there will be no reabsorption too. So it's throughout the glomerular capillaries. It's not only in the efferent or the afferent arteriole. It's the glomerular capillaries itself. Pressure. When the colloid pressure of the artery is stopping. I'm sorry, but I don't get the question. Can you reword the question? No, it's throughout the glomerular capillary itself. So it's not afterwards. So throughout the glomerular capillary, from the beginning till the end. Did I answer your question, or do you want me to explain the whole thing again? Okay. Perfect. Okay. Now let's talk about the effect of renal plasma flow on GFR. So let's assume that the renal plasma flow, the normal renal plasma flow is 600. Okay. So and the GFR is 120. We said that we need the colloid osmotic pressure to be equal to the hydrostatic pressure for the filtration to stop. So for in this case, for the 600 renal plasma flow, you needed 120 milliliters out of these 600 milliliters per minute for you to stop the filtration. Okay. So when you increase the renal plasma flow, you would require more GFR to reach the same hydrostatic pressure. So again, let's assume that the normal renal plasma flow is 600. Okay, for you to reach for the oncotic pressure to be equal to the hydrostatic pressure, it needs this amount. Let's say 120. Okay, it needs to filter 120 milliliters per minute for it to reach the hydrostatic pressure. Okay, so if by logic, if you increase the renal plasma flow, you at some point you have to increase the GFR for you to have this the hydrostatic pressure and the oncotic pressure to be of the equal point. More filtration. Yeah. You mean more GFR? Yeah, exactly. So you need to filter more for you to reach again. So you need to filter more. This is why the GFR is increased, because you have an increased renal plasma flow. So you need to filter more for you to reach for the oncotic pressure to reach to an equal point to the hydrostatic pressure. Did you get it? Mm, okay. So this is normally what happens. Okay, you have a 600 milliliter per minute of renal plasma flow. So if for you if the kidney needs to filter 120 milliliter per minute out of the 600 milliliter per minute to reach this, then if you increase the renal plasma flow, it would definitely mean that you have to filter more for you to reach the same point. This is simply how you want to understand the renal plasma flow. Okay. So in summary, if you increase the renal plasma flow, you're also increasing the GFR. Okay. If the renal plasma flow is decreased, the GFR will decrease. This is what you need to understand from this slide. I don't remember him asking about the mechanism exactly, but what you need to understand is that there is a direct relationship between the two. Increase in renal plasma flow will cause an increase in the GFR. Okay, so in this slide, it's just a hypothetical scenario. Okay, so in the kidney, you have the renal artery. Let's say this is the renal artery, and then you have the arteriole, then the glomerular capillary, efferent arteriole, and the peritubular capillary. Okay, let's say that the normal renal artery pressure is 100. Okay, and then the peritubular capillary pressure is 20. And we put that the one for each 100 for each arbitrary unit of 1, the pressure will be decreased by 40. Okay, let's say that. So 100 will be decreased by 40, and it will become 60. Okay, then the resistance is still 1, so you're also decreasing by 40, so it will become 20. This is for the normal. So again, the renal artery pressure is, let's say, 100, and if for every 1 arbitrary unit, you're decreasing the pressure by 40. Okay, so if 100, you're cutting down 40, so it will become 60. The glomerular capillary pressure will become 60. You're also cutting 40 again because it's 1. Then the pressure will become 20. This is if you keep the pressure in both the efferent and the efferent equal. So the total pressure is the total resistance is equal, because 1 plus 1 is 2. You would have the same final pressure. Okay, let's move on and let's increase one and decrease the other. So if we increase the efferent, so increase efferent by 0.5, and we decrease the efferent by 0.5 also. So the total resistance now is also equal. You have 1.5 plus 0.5, it's still 2. And here 1 plus 1, it's still 2. So you would have the same final pressure, but by changing the resistance in the efferent or the efferent, you're only changing the glomerular capillary pressure. So you're not changing the final peritubular capillary pressure. You're only changing the glomerular capillary pressure. The same goes if you increase the efferent resistance. So you increase this by 1. So you made this 1.5, and you decrease this to 0.5. So the total resistance here is what? Is still 2. Okay. So you would have from 100 in the renal artery pressure, you would still have 20 in the peritubular pressure, peritubular capillary pressure. But what's going to change is the glomerular capillary pressure. So it will either increase or decrease. And how would that be? Because let's think about it without looking at the numbers. Okay, so if you're causing more constriction here, so less of the blood or the fluids will go on into the glomerular capillary. So this is the reason why it will decrease. The pressure will decrease because the fluid is what causing the pressure. So, however, if you decrease the resistance here, so more fluids will go into the glomerular capillary, and it will cause more pressure. So you have to think about it in terms of efferent or efferent. These two, the efferent and efferent resistance, is what controls the glomerular capillary pressure. If you increase one, okay, the glomerular capillary pressure will either increase or decrease. So this is just, as I said, hypothetical scenario. In real life, that usually doesn't happen. Okay. However, in this slide, what he wants you to understand is that if you keep the total resistance equal, you will not change the peritubular capillary pressure, but you'll only change the glomerular capillary pressure. That's what he needs you to understand in this slide. Is that clear? Because in the beginning I had a difficulty understanding the concept, but for the second one we decreased efferent. Why? Because the total resist the second one we decrease efferent. Why? Because the total resistance is the same. If the total, yeah, because the total resistance is the same, so the pressure will not change in the peritubular. So the only time where the yes, pressure that yes, it's always like this. So if the total resistance for the efferent and efferent is so if the total resistance is equal, so here in the first case it's 2. Whether you in the next case you increased 1 and you decreased 1, but the total resistance is also is still 2. The third case you decreased 1 and you increased 1, but the total resistance is still the same. So you won't this will not affect the peritubular capillary pressure, but it will affect the glomerular capillary pressure. But this is just a hypothetical or theoretical case. This won't happen in real life. The only pressure that changes is only the yes, exactly. This is the only pressure that changes. Other pressure doesn't change. Any other question here? Sorry. Okay. So in the next 2 slides, I'll show you what happens in reality. Okay. So in reality, you have constriction of either the efferent or the efferent. Okay. So what happens in the constriction of the afferent arteriole? So if you let's say if you constrict the afferent arteriole, what do you think will happen to the hydrostatic capillary hydrostatic pressure? If you constrict this, there will be less fluid going to the less blood going to the glomerular capillary, and there will be less pressure, right? So this is what it shows here. If you constrict the afferent, there will be less blood going into the glomerular capillaries. There will be less pressure. So as you increase the resistance or you're increasing the constriction, the hydrostatic pressure will decrease. Okay. What do you think will also happen to the renal plasma flow? Do you think it will increase or decrease? It will decrease. And the reason for that, in the previous slide, there's a formula here. It says flow is equal to the change in pressure, okay, divided by resistance. So now here you're increasing the pressure, you're increasing the resistance. So the flow should be what? Should be decreased, okay? So in the efferent arteriole, you're increasing constriction of the efferent arteriole. You're increasing the resistance. Because you're increasing the resistance, the flow will decrease. This is the reason why the renal plasma flow will decrease with constriction. So, and let's see the net effect of each of these two. If we decrease the hydrostatic pressure, what do you think the GFR will be? Will it be increased or decreased? So here, if we increase this one, Okay, what do you think the GFR will be? You're increasing this one, so more fluids are being filtered. So GFR should what? The hydrostatic pressure is in that case, in this case, okay, the hydrostatic pressure is decreasing, right? So you're decreasing the hydrostatic pressure. So GFR should what? You're not filtering more. So GFR should decrease. Yes. Also, renal plasma flow is decreasing. And we said that if you increase the renal plasma flow, you're increasing the GFR. If you decrease the renal plasma flow, you're decreasing the GFR. So both hydrostatic capillary pressure is decreasing, and it's decreasing the GFR. Renal plasma flow is decreasing, and it's decreasing the GFR. So the net effect is what? Is the GFR will be decreased. This is if you have constriction of only the afferent arteriole. Is that understood? So you will look at each factor alone, okay? First, we have the hydrostatic pressure, if it will increase or decrease, and how will it be, how will it affect the GFR, and then the renal plasma flow, and how will it affect the GFR. And in the constriction of only the efferent arteriole, the hydrostatic. So you're constricting here, okay, before the glomerular capillary pressure. So less blood is going into the glomerular capillary. This is why the hydrostatic pressure here will be decreased, okay? So the hydrostatic pressure will be decreasing. Renal plasma flow will be decreasing. Why? Because we said that if we increase the resistance, or in other words, we're constricting the efferent arteriole, so we're decreasing what? The flow. So the renal plasma flow will be decreasing, and the net effect of both of these factors will cause a decrease in the GFR. Is that understood? Okay. Okay. Now that we're done with the efferent arteriole, let's move on to the efferent arteriole. And the efferent arteriole, okay, you're constricting after the glomerular capillary. So more blood, the constriction is after the glomerular capillary. So the blood will be flowing more into the glomerular capillaries, and this will cause the hydrostatic pressure to increase. This is what happens. The hydrostatic pressure will increase. What do you think the renal plasma flow, what will happen to the renal plasma flow? Will it increase or decrease? Use this formula. It will tell you whether the renal plasma flow will increase or decrease. R increases, so it will decrease. Yeah, exactly. The renal plasma flow will decrease. Why is that the case? Because you're increasing the resistance, and because the resistance is increased, the renal plasma flow will decrease. It's inversely proportional. The resistance is inversely proportional to the renal plasma flow. So you have the two factors are antagonizing each other. So you have the hydrostatic capillary pressure is increasing, but the renal plasma flow is decreasing. So now you need to know which one is dominant. Is it the hydrostatic pressure or the renal plasma flow? So with moderate constriction, or if the resistance is not very high, you would have what? An increase in the GFR, okay? But if you have severe constriction, that means that you're increasing the resistance, then you will have the GFR will decrease. So again, in the efferent arteriole, you're increasing the hydrostatic pressure, okay? And because you're increasing the hydrostatic pressure, the GFR should increase. The renal plasma flow, we said it's decreasing because you're increasing the resistance. So the effect of the renal plasma flow on the GFR is decreased GFR. Now you have one factor that is increasing the GFR. It's this factor, the hydrostatic pressure, and the other factor is decreasing the GFR. And now you need to know which one is dominant, and this depends on the degree of constriction. If the constriction is moderate, you will have increased GFR. If the constriction is so severe, or there is more resistance, you would have decreased GFR. So in efferent arteriole, in constriction of efferent arteriole, you'd have only one scenario where there will be always the GFR will always decrease in the constriction of only efferent arteriole. However, in the efferent arteriole, the GFR depends on whether there is a moderate or severe. Moderate constriction, the GFR will increase. Severe constriction, the GFR will decrease. Is that clear? So for you to calculate the GFR, this is one formula that you can use to calculate the GFR. GFR is equal to Kf. This is a constant, okay, multiplied by the difference in the hydrostatic pressure minus the difference in the oncotic pressure. So let's take each of these factors and explain what will happen to the GFR if we, for example, decrease this or increase this. So the hydrostatic in the capillary. If we constrict the efferent arteriole, as we said here, the GFR what would happen to the GFR? It will decrease, okay? So if we constrict this, if this one decreases, so the GFR will decrease. And this happens in the case of what? Constriction of the efferent arteriole. If we constrict the efferent arteriole, okay, we said that GFR depends on, the GFR will depend on two things, on the degree of constriction. If it is moderate, it will increase. If it is severe constriction, it will decrease, okay? This is in regards to the hydrostatic pressure of the capillary. Now the constant, it will happen when in nephritic syndrome. If you have a nephritic syndrome, the constant will decrease, and this will cause the GFR to be decreased, okay? Now, the hydrostatic pressure in the Bowman space. When do you think the hydrostatic pressure here will increase? When do you think there will be congestion of urine in the urinary system? Can you think of any reason that could increase the Bowman space hydrostatic pressure? Not an injury specifically. So basically, when there's a stone, like a kidney stone, let's say in the ureters, okay, the fluid will build up here. Okay, the fluid will not be able to go from the kidneys into the bladder, let's say, and then the fluid will build up. So this will increase the Bowman space hydrostatic pressure. This is the case this is like a typical case where the Bowman space hydrostatic pressure will increase. In this case, because the Bowman space hydrostatic pressure increase, there will be less GFR, okay? Because this force is the hydrostatic pressure in the Bowman space is opposing the hydrostatic pressure in the capillary. So because this is bigger than this, there will be less filtration and less less GFR. Okay. Capillary oncotic pressure, the capillary oncotic pressure will increase by dehydration. So if you're dehydrated, there will be not too much fluid in the blood. So because there's not too much fluid in the blood, the proteins will precipitate. So there will be an increase in the oncotic capillary oncotic pressure, and this will reduce the GFR, because this force usually is a suction force. It will move the fluids to its side. Okay. However, the oncotic pressure will decrease by hunger. And why is that the case? Because in hunger, the body will metabolize the body proteins to make energy, or to make ATP. Okay, so there will be decrease in the proteins of the body, and because there is a decrease in the proteins, the oncotic pressure will decrease. And because there's no oncotic pressure, there is no pulling force to the capillary, there will be more filtration, and the GFR will increase. The oncotic pressure of the Bowman space, we said normally it's 0, because we usually don't filter proteins unless we have a disease of a disease in the podocytes, which is which disease? It's one of the glomerular diseases. Nephrotic, yeah, exactly. In nephrotic, the podocytes are injured. Okay, so you won't be able to prevent the proteins from being filtered. So proteins will be spilled into the Bowman space, and this is when the Bowman space oncotic pressure increases. Okay, but normally it's 0. Finally, the renal plasma flow, and we saw how the effect of the renal plasma flow causes an increase in the GFR. So these are the factors that plays a role in the GFR. Is that clear? Okay. KF is a constant. It's always a constant. Basically, it gets reduced. That's the only thing that you need to understand. It gets reduced with nephritic diseases. So if this number is, let's say normally it is 10, but now you have a let's say a nephritic disease, and now it becomes 5. Okay. Do you think the GFR is increased or decreased? Since it will be multiplied by the difference of all of this, then the GFR should definitely decrease, because normally it's 10. Let's, for example, say it's 10, but because of the anephritic disease, you have now 5. So the GFR should ideally decrease. Is that understood? Yeah, like you don't need to understand the nephritic and the nephrotic diseases, like because I don't think he'll get you questions about those, but just understand nephritic will cause what? Will cause a decrease in the KF. However, nephrotic will increase the Bowman space oncotic pressure. Okay. Now moving on to the last part of this lecture, the autoregulation. Now in the kidneys, you have different vessels. You have the renal artery. You have vas afferens is the efferent arteriole. Then you have the glomerular capillary, efferent arteriole, peritubular capillary. Then it becomes the intrarenal vein. vein, renal exit, and then the renal vein, and finally to the heart, to the inferior vena cava and to the heart. So what the doctor wants you to understand from this slide is that there's a drop in pressure. So let's say that normally you have a mean arterial pressure of 100. Okay, the drop in pressure usually happens in the arterioles, the efferent arteriole and the efferent arteriole. You can see that in the renal artery, let's say the mean arterial pressure is 100, then you have a big drop in the pressure in the efferent arteriole. Then in the glomerular capillary, the pressure is again constant. Efferent arteriole, there's another big drop, and then it becomes constant. There's a small drop here, and it becomes constant. So what he wants you to understand is that the efferent arterioles, the efferent and efferent arterioles are responsible for adjusting the renal pressure, okay, or the pressure going to the kidney. And this is because these arterioles are they control the resistance. You remember when we said if you have an increased resistance, you have a drop in the pressure. If you have a decreased resistance, you have more pressure. This is the reason why the vas efferens and the efferent arteriole and the efferent arteriole, there's a drop in the pressure, and this can be seen in someone who is hypertensive. So let's say someone has a blood pressure of 180. You would notice that once the pressure in the renal artery, it's the same as the heart. So he has 180 what is it called? 180 millimeters of mercury. Yeah. So the biggest drop will be where? In the efferent arteriole. But then you have the glomerular capillary, the pressure will be constant. Efferent arteriole, there will be another big drop in the pressure, and then it will become constant. So what you need to understand from this slide is just that the efferent and the efferent arteriole is what controls the pressure, and this is because they are the sites of the sites of the highest resistance. Okay. The other vessels, they don't have much resistance, so that's why the pressure inside them is almost constant. Okay, so autoregulation. Now, let's say someone has a blood pressure of 90. Okay, let's say this is 90. Okay, so as the blood pressure increases, the renal plasma flow and the GFR will also increase. Okay, this is a rule. It will increase until it reaches a point of 100. So from 100 to 200, the kidneys has mechanisms that will maintain the renal plasma flow and the GFR. It will keep them constant throughout this range of blood pressure. So from 100 to 200, the renal plasma flow and the GFR will become constant. They will not fluctuate. And this is a protective mechanism, okay? And this autoregulation mechanism is mediated by two mechanisms, the myogenic mechanism and the tubuloglomerular feedback tubuloglomerular feedback mechanism. So for autoregulation, it's a protective mechanism. Okay, its main function is to maintain a constant renal plasma flow and glomerular filtration rate over the ranges of blood pressure from 100 to 200. Okay, so what are these two mechanisms? We said the first mechanism is the myogenic mechanism, and the way to explain this is when you have a lot of blood going to the efferent arteriole, for example, there's an increased blood pressure. Let's say because of the increased blood pressure, there will be an increased pressure against the walls of the efferent arteriole, because more fluid is going to the efferent arteriole, so more of the fluids, the fluids will cause pressure on the walls of the efferent arteriole. And the efferent arteriole walls, they have a mechanosensitive calcium channels. So when these mechanosensitive calcium channels, they sense that the pressure is increased, so what will they do is they release calcium into the smooth muscles, okay? And when calcium is released into the smooth muscles, it will cause vasoconstriction. So it will cause vasoconstriction, so less blood will be going into the kidneys. So this as a result will cause decreased renal plasma flow. It will decrease the blood pressure. It will also decrease the GFR. So again, if the blood pressure, let's say, is increased, or the renal plasma flow is increased, because of the increased blood pressure, there will be more pressure on the walls of the efferent arteriole. The efferent arterioles, their walls have stretch receptors or mechanosensitive calcium channels. The stretching of the walls will cause what? Will cause the channels to be open. And when the channels are open, the calcium will be released into the smooth muscles of the vessels of the efferent arterioles. So when the calcium gets released, it will cause vasoconstriction. And when it causes vasoconstriction, it will decrease the blood going to the kidneys. And because the blood going to the kidneys is decreased, it will cause a decrease in the GFR. And this is the reason why there is an autoregulation. So from 100 to 200, this is what happens. If the pressure gets increased, this is what one way of making sure the renal plasma flow and the GFR becomes constant. Is this mechanism clear? Okay. Okay. The second mechanism is called tubulo-glomerular feedback. From the name, it means it involves two structures, the tubules and the glomerulus. In the tubules, there's cells called macula densa cells. These are specialized cells in the distal convoluted tubules. And let me show you how it will function to make sure that the GFR and the renal plasma flow is constant. So this is the tubular fluid. Let's say there is increased GFR, or there's an increased blood pressure, for example. Because of the increased blood pressure, there's an increased GFR, okay? So more fluid is going into the tubules. Now, because more remember when we said that most of the substances that are filtered contain sodium and chloride, okay? Now, more substances, the fluid here contains more sodium and more chloride. Now, because there's more sodium and more chloride, the macula densa cells, it senses that there's more sodium and more chloride, and it takes this sodium and chloride into the cell. So when they go into the cell, okay, the sodium increases in the cell, and it uses this transporter, okay, and this transporter uses ATP. So it converts ATP to ADP, okay. So sodium then is moved into the interstitium. However, the ADP that is produced, we don't care about the sodium, but we care about the ADP and the ATP. So because this transporter uses ATP and converts it to ADP, then the ATP will move to the outside of the macula densa cells, and it will bind to its receptor on the vascular smooth muscles. So once it binds to its receptors, it will cause what? It will cause the calcium channels to be open, and because calcium channels are open, it will cause constriction again, constricting the efferent arteriole and resulting in the same mechanism. Constriction of the efferent arteriole will decrease the GFR. So also, because calcium is increased in the these are the vascular smooth muscles, and these are the granular cells. Granular cells, they have vesicles that contain renin molecule. So because calcium is increased in the granular cells, it will decrease renin. And I will explain in the next slides what's the importance of renin. But renin mainly will cause more reabsorption it will activate the renin-angiotensin system, and it will cause more fluid to be reabsorbed. And that's what you don't want to do, okay? So this is why this mechanism will decrease the renin, but it will cause vasoconstriction. So by decreasing renin and causing vasoconstriction, it will result in less GFR. Is that clear, or should I repeat it? So, okay. So again, GFR is increased. For example, let's say because of an increased blood pressure. Okay. Now, because there is an increased blood pressure, there will be an increased GFR. So more fluids, more substances are filtered. And from these substances, we said that most of these substances are sodium and chloride. Now, these substances are in the tubules, okay? And in the distal convoluted tubules, you have the macula densa cells. These cells, once it senses that sodium and chloride is more in the tubular fluid, it will reuptake these substances into the cell, okay? And then once it reuptakes sodium, it uses this transporter to move sodium from the cell itself to the outside. And upon doing this process, it will use ATP. So ATP will be converted to ADP. This ADP and some ATPs will move to the outside of the cell. They will bind to their receptors. So ADP will bind to its receptor A1. ATP will bind to its receptor B2X. And these two receptors will cause the calcium channels to open. Now, because the calcium channels are open in the vascular smooth muscles, they will cause vasoconstriction. So because they cause vasoconstriction of the efferent arteriole, we said that they will decrease the GFR. And not only they will cause vasoconstriction and decrease GFR here, but they will do that also by the calcium will also have a role in the granular cells. The granular cells have the renin vesicles. Renin vesicles, the molecule renin will activate the renin-angiotensin system, which you don't want to activate. So calcium will decrease the renin release. By this, the net effect of both vasoconstriction and decreased renin release is decreasing the GFR. So by this, you're maintaining a constant renal plasma flow and GFR. Did you get it? So the cell that has these vesicles is the granular cells. It has the renin cells. However, this cell is the vascular smooth muscle. It is there for the vasoconstriction. However, this cell is there for renin release. Now, because calcium is increased here in the vascular smooth muscle, it will cause vasoconstriction of the efferent arteriole. But in the granular cells, because calcium is increased, it will decrease renin release. So as a result of both of these effects, the GFR will decrease. So now we have talked about the two mechanisms, the myogenic mechanism and the tubulo-glomerular feedback. These two mechanisms are used again in autoregulation. Autoregulation is what? It's a protective mechanism by the kidney It's there to make sure that the renal plasma flow and the glomerular filtration rate is constant throughout this range of blood pressure from 100 to 200. Above 200 and below 100, the renal plasma flow and the glomerular filtration rate will increase with increased blood pressure. However, it will decrease with decreased blood pressure. Okay, so regulation of the renal blood perfusion. So we have already talked about the myogen mechanism and the tubular glomerular feedback. There's also other mechanisms by the sympathetic activity. So if there's a moderate sympathetic activity, the effect will be dominant on the efferent arteriole. Okay, so the GFR remains unchanged. However, if the sympathetic activity is severe, the effects will dominate on the afferent arteriole, and the GFR will decrease. Other mechanisms which other mechanisms is the renin-angiotensin-aldosterone mechanism, which I will explain in the next slide. There's the ANB. It's a protein that is produced in the body. It will act on the efferent arteriole. It will cause dilation of the efferent arteriole. So because the efferent arteriole is dilated, so it will increase the renal plasma flow and the GFR. Prostaglandins or nitric oxide are also substances that are produced by the body. They will dilate the arterioles, causing again renal plasma flow and GFR to increase. Okay, so if there's dilation, there will be increase in renal plasma flow and GFR. If there is constriction of the efferent, we said the GFR will decrease. Okay, last top concept is the renin-angiotensin system. So it gets activated if you have a drop in blood pressure, okay, and if you have a drop in the fluid volume. So because let me go back to this slide. So the way to understand it is basically if you have a decrease in the GFR, we said that increase in GFR will cause what? Decreased renin release. So the opposite is true. If there is a decrease in the GFR, less sodium will be there. So there will be less calcium release, and renin, there will be more renin release. Now, because there is more renin release, okay, the renin will be released from the kidney, and the liver produces a substance called angiotensinogen. Okay, renin will change angiotensinogen to angiotensin 1. Okay, so renin acts on the angiotensin. Renin acts on the angiotensinogen to form angiotensin 1. Then the lungs produce an enzyme called angiotensin converting enzyme is released from the lungs. It converts the angiotensin 1 to angiotensin 2. Then angiotensin 2 has multiple effects. It goes to the blood vessels. It causes vasoconstriction. It goes to the adrenal medulla. It releases aldosterone, and then aldosterone acts on the kidney and causes reabsorption of sodium chloride and water. And by reabsorbing water and calcium chloride, you're increasing the fluid in the body. So by increasing the fluid, you're increasing also the pressure. So this is again, if you have a decreased renal plasma flow, if there's a decreased blood pressure, or if you have a hyponatremia, renin will be released from where? From the kidneys. Okay, renin will act on the angiotensin. Renin will act on the angiotensinogen from the liver. Okay, it will convert it to angiotensin 1. Then angiotensin 1. Angiotensin 1 will be converted to angiotensin 2 by the ACE inhibitor of the lungs. Angiotensin 2 is what does the effects. Okay, it has an effect, as we said, on the blood vessels, causes vasoconstriction, Vasoconstriction will increase the resistance. So because they increase the total peripheral resistance, they're increasing the blood pressure, so bringing back the blood pressure to normal. They'll also cause release of ADH from the hypothalamus, and ADH goes to the kidneys and cause water reabsorption. So again, you're increasing the blood pressure. It will angiotensin 2, as we said, will go to the adrenal medulla or adrenal gland, and it will cause release of aldosterone. Aldosterone goes to the kidneys, causes water and sodium reabsorption in the kidneys. And finally, the angiotensin 2 acts on the hypothalamus and causes thirst. So it makes you drink more water, and because it makes you drink more water, you're increasing the body fluid, and this is another way of increasing the blood pressure. Okay, so this is we reached the end of the lecture. Does anyone have a question? Okay, so I have like 3 questions here. Should G&D, should I answer them, or should I just send you the PowerPoint? And okay, since we're out of time, the 3 questions are there for you to solve. The answers are in the notes sections, okay? And please scan the code to give your feedback. And thank you. If you have any questions, my number and email is the last slide, so you can ask me at any time. And I'm not sure if you're the person who asked about the R factor. I'll make sure when I send the presentation to the to GND to make sure to add a slide about the R factor.